Great. So I see in Nairobi, a lot of people from Nairobi. Welcome. I see San Francisco. I see New Jersey. I know somebody's from Boston in the group, so welcome. Nairobi. Yeah, welcome, Angela from Boston, Connecticut. Thank you all for joining. We'll be starting in a few. So let's just give it another 2 or 3 minutes before we can start. So for those that are joining us, please introduce yourself so we know who's in today's conversation. I'll reintroduce myself again. My name is Catherine Kilelu. I am based at the African Center for Technology Studies, and we are going to be co-hosting this webinar with the Calestous Juma Legacy Foundation. So welcome. Please let us know where you're joining us from. Okay, we're about 4 minutes after the hour. I think we probably can start since we have a very packed agenda. Yeah, welcome once again. And to kick us off, I'll invite my executive director, Professor Ogada, to introduce himself and welcome us to this webinar. So, Prof, welcome.
Okay, thanks very much, Catherine. Ladies and gentlemen, good afternoon and good morning, depending on where you are. Allow me, on behalf of the African Center for Technology Studies, to sincerely welcome you to this webinar today, which is a relaunch of the CJLS seminars. And today we are delighted that we are going to have a very, very powerful presentation from one of us, the title Challenges and Opportunities in Women and Maternal Health in Africa, Leveraging New Tools for Scale and Impact. Before that, I would like just briefly, for the benefit of those who may be hearing for the first time about the African Center for Technology Studies, to indicate that this is a science, technology, and innovation policy think tank that was established in 1988 by the late Professor Calestous Juma, specifically to support African countries and institutions to harness science, technology, and innovation for sustainable development. We are delighted to mention that we have remained true to the aspiration of this great STI guru in Africa and globally, and as a way of immortalizing him, we decided to organize CJ Seminar Series, and this took place several times during the year 2021, 2022. We took a small break, and we are delighted that today we are relaunching it again, and we look forward then to continue engaging you on the same going forward. So our speaker today will be Dr. Moses Obimbo Madadi. I know I'll be introducing him into greater details later. Otherwise, for now, I'll stop here and pass the microphone to Angela. Thank you.
Thank you, Prof. I would like to welcome everyone on behalf of the Calestous Juma Legacy Foundation. Thank you so much for joining us today. Our foundation was founded to continue to realize Calestous Juma's dream of a thriving Africa where people and communities flourish through locally driven, sustainable solutions powered by, you guessed it, science, technology, and innovation. And that's why we're so well aligned with the African Center for Technology Studies. You can learn more about Calestous Juma and our work on our website, which is calestousjuma.org. I'm actually going to be very brief today because I like to bring Calestous into the room and have him speak for himself. So today I'm very honored to share a very short video clip from 2009 of Professor Calestous Juma speaking at the University of California about medical innovation, and it is related to our topic today. Now, it's a little bit outdated, but we wanted to bring Professor Juma into the conversation. So I invite you to enjoy this video clip.
The same thing is happening in the area of health with the emergence of mobile health, largely because a large proportion of healthcare is in fact associated with the management of healthcare information. And we're starting to see basically improvement of various technologies, especially in the diagnostic field, that are IT-based, where IT is the platform. And one example, this is something I've been associated with a little bit with colleagues of mine at the Harvard Medical School. This is an ultrasound equipment I would say about 10 years ago, it cost roughly $20,000. And so it was inaccessible for most developing countries. Certainly for most African countries, you find this equipment only in major hospitals. At least that's where you found them. And so 5 years ago, a company in Seattle developed this initially for the military. It's a ruggedized ultrasound equipment you could put in your backpack and essentially take it anywhere. And I was working with colleagues of mine to try to figure out how to get these units into African hospitals. And just before we made a commitment, a colleague of mine called me up and said, don't make that commitment. There's actually a major improvement in the technology that is coming along that is smaller and cheaper. And indeed, this is as of March this year, FDA approved this Australian designed technology, which is a very small ultrasound unit, which you plug into the computer and just read the images. And I was really excited about this one, and I got another phone call saying, no, don't get too excited. This costs about $2,000. That somebody has developed something that is likely to cost $100. And there it is, developed by engineers, electronic engineers at the University of Washington in St. Louis, where the image is transmitted onto a cell phone. And essentially, if the doctor can't interpret the image, the doctor will just simply send you back a text message saying, please do it again. This is all personal diagnosis. Now, you can actually tell that these two gentlemen are not medical doctors, because if they were, they would know very well not to look for pregnancy right there.
So hopefully that gives you all a sense of who Professor Juma was and why we're so keen on honoring him and his legacy. We are now going to start our first interactive session for the day, and I want to pass the floor back to Dr. Kilelu, who will guide us through a quick poll. Thank you.
Thank you so much, Angela. And yeah, it's indeed really powerful to see the thinking of Professor Calestous Juma and how his insights into science and technology really resonate with us today. So what we're going to do before we delve into the topic of the day, we just want to have a sense of how we understand the topic of maternal health, and especially in relation to the burden in the continent. So we're going to just allow you to test your understanding or your knowledge, your general knowledge about this issue. So we've launched a poll. It's about 3 questions that should take you about 30 seconds max. And we just want to have an understanding of where do you gauge or where do you see the burden of this particular issue of maternal health. So if you could quickly just answer the questions that have popped on your screen. And you need to scroll down to be able to answer everything and then to submit the poll. So just answer the 3 questions and then submit your responses. Then we'll quickly look at, how that is looking like, and then we can get into the topic itself. So I'll give you about 20 seconds to do this. So I can see we've got about 17 people who've responded out of the 47. So if you kindly can just try and guess if you have to, that's okay. Okay, you can see the responses coming in. Okay, we're almost there. So another 10 seconds, your chance to respond if you haven't. Okay, I think we have an adequate response. About 33 people have answered. So maybe, Peter, could you just end the poll and we see what the results look like? Yeah, so I think I see that majority of the people have responded that 1,500 people die globally. So this is globally, how many women die each day from preventable diseases related to pregnancy and childbirth. So 1,500, about 45%. Then which region accounts for the highest burden of maternal deaths? We see Sub-Saharan Africa. Majority of the people, 94%, say Sub-Saharan Africa. And then what would be your preferred treatment for vaginal infection? We see antibiotics, probiotics, dowshing, and traditional herbs. So we see antibiotics at 58%. So Peter, you can stop sharing the results. I think we can give it to now Professor Obimbo, who will tell us if the responses were correct, even as he gets to his talk. So at this point, I will bring the mic back to Professor Ogada to introduce Professor Obimbo officially. So, Prof, back to you.
Thank you very much. That was a very useful exercise, and I think it has prepared us better, even now, to listen to Professor Obimbo Moses Madadi. It is now my distinct honor to introduce him as our keynote speaker today. Professor Obimbo is a Calestous Juma Science Leadership Fellow, a renowned scientist, a practicing obstetrician and gynecologist, and a passionate professor dedicated to improving women's health. He holds a prestigious position as the chairman of the Department of Human Anatomy and Medical Physiology at the University of Nairobi, and serves as the honorary secretary of the Kenya Gynecological Society. Dr. Obimbo's groundbreaking research focuses on using advanced omics to uncover key pathways in reproductive science, with the goal of developing new diagnostic and therapeutic targets. Beyond his scientific work, he's a true innovator in advocacy. He led a team in successfully launching a Run for Her, the world's first ever postpartum awareness run, a pioneering initiative that has since gained global recognition and is now in its second year. Professor Obimbo is also at the helm of a team exploring the vital role of the microbiome in women's and global health, with specific focus on pregnancy outcome and reproductive performance. With this unique blend of clinical expertise, scientific rigor, and advocacy, is ideally positioned to build capacity and mentor the next generation of translational scientists in Africa. Ladies and gentlemen, please join me in giving a warm virtual welcome to Professor Obimbo Moses Madadi to give us a keynote speech. Over to you, Professor Obimbo.
Thank you very much, and thank you, Professor Ogada, and thank you, the Calestous Juma Foundation, for inviting me to, as an honor, to give the first of the series of lectures in honor of Calestous Juma, who is a true hero and a really blessing to our country, a true son of our soil. So I'll go ahead and make a presentation on the work that we are doing. And it will be focusing more on the challenges and opportunities in women's health and maternal health in Africa, and how we are able to leverage new tools to scale and to make sure that we have impact. As I've been introduced, I'm from the University of Nairobi, and I'm also blessed to be a Calestous Juma Science Leadership Fellow under the Gates Foundation. So my work and our group is really inspired by this great leader, Michelle Obama, who notes that communities and countries and ultimately the world are only as strong as the health of their women. And I always add to this that I am who I am today because my great-great-grandmother was healthy. Were she not healthy, then my health would definitely not be okay today. So it therefore means it's incumbent upon all of us to ensure women's health and maternal health is guaranteed, not just as a women's health issue, but also as a human rights issue and a security issue as well. I want to start by noting the global burden suffered by especially our women and in maternal health in sub-Saharan Africa. In 2023, for example, it was noted that about 260,000 women lost their lives due to pregnancy-related complications. Out of this, about 180,000 were in sub-Saharan Africa, accounting for about 70% of all global maternal death. Something to note is that most of these deaths did not need to occur. They were preventable and treatable, but they still happened. In so doing, most families lost their mothers, children were left orphaned, most fathers had their daughters die, we had our sisters die, and so forth. So this is a real issue that we need to be able to tackle in Africa. So in my presentation, I'll be looking at some of the challenges that we experience that, of course, affect us more than anywhere else in the world, including the poor pregnancy and neonatal outcomes that disproportionately impact us here in sub-Saharan Africa. We also look at the high burden of preventable maternal death. As I've indicated, in Africa, we lost about 180,000. In Kenya, we lose about between 5,000 to 7,000 women every year because of preventable conditions. This is also in keeping with the issue of triple burden. So in addition to getting complications from pregnancy-related conditions, our women also suffer from neglected tropical diseases such as schistosomiasis, leishmaniasis that no one seems to address. And then the other burden that really is afflicting our women is the non-communicable diseases, gestational diabetes and diabetes in general, preeclampsia and hypertensive conditions that also affect our women disproportionately. I'll also touch on the emerging science of microbiome and how it's important and its role it plays in the maternal and neonatal health outcomes, and then see some how we can be able to mitigate some of these challenges by innovating on opportunities to improve and make sure that we are able to get science and technology work for us to improve maternal and women's health. So I give a bit of my story, and it begins and centered on women's health research. And this straddles between doing research on basic science and being a gynecologist working on the bedside and seeing really the challenges that affect women, both in cases of gynecology, but in cases of also pregnancy and the conditions that affect these women during pregnancy. And now working as also a women's health advocate, based especially on the problems that we see on the bedside and the challenges that we experience at the bench, and not being able to translate the work that we're doing at the bench to actually have meaningful change within the society. So it's therefore important to demonstrate that we're able to bridge the gap between the research that we do at the bedside, the clinical work and the challenges that we get, and where it really meets the megaphone on the streets. And the images on the right demonstrate what we actually been doing. So my early research focused on uterine vascular system, and I was able to study both the human and the porcine uterine vascular system. Here was basically to look at the physiological adaptation and how this physiological adaptation leads to anatomical changes within this vascular system. And the key findings from these studies have been very much relevant to understanding the blood flow during the different parts of pregnancy and also in different physiological state, from prepubertal stage to a woman who is just in reproductive age group to women who are in pregnancy, and how they speak to some of the complications that occur during pregnancy. Later, my group focused on studying the placenta, and we still do this both at the University of Nairobi and my colleagues at the neighboring university, Mount Kenya University and UCSF, where we're able to explore the impact of HIV and highly active antiretroviral therapy has on placental biology and preterm birth. So we did some work on this, and we were able to demonstrate how the HIV itself and or antiretroviral affect pregnancy outcomes, and also how it affects and contributes to the occurrence of preterm birth. My group has since been able to study the various aspects of placenta biology, from placenta and anemia, placenta and nutrition, placenta and diabetes, placenta and preeclampsia, placenta malaria, and how these are able to affect the structural biology of placenta, giving credence to various hypotheses that then can answer questions on how we can intervene at the placental level to ensure good pregnancy outcomes. Our current research also focuses quite a lot on vaginal microbiome and vaginal health, and this is the work that is funded currently by the Gates Foundation under Calestous Juma Science Leadership Fellow. And the background to this is that within the vagina, we have what we call the normal flora of the vaginal microbiome, and it's composed mainly of the lactobacilli. And the lactobacilli maintains the vaginal environment through various mechanisms, first just by lowering the vaginal pH and ensuring that pH is adequate for the vaginal health. It also competes with for nutrients with offending bacteria, and therefore outcompeting them and preventing these infections, and also causes immunomodulation, but most importantly also releases bioactive substances within the vaginal microenvironment to ensure health. This environment changes from time to time, and there have been various studies that have been done in non-pregnant state, but we also know that during pregnancy, there could be change within the vaginal microenvironment and the vaginal microbiome. And how this is important is that we expect less diversity within the vaginal microenvironment to ensure health. There have been studies that have shown different populations having different predominance of the different lactobacilli, but not so much has been done within our environment. This goes and is keeping hand in hand with reproductive tract infections, whether they are symptomatic or asymptomatic, which is a very important clinical and public health concern. Some studies that have been done before demonstrate that about 73% of women who have potential infections actually do not know they have these vaginal infections. And those who have infections, it's very difficult to treat them. And therefore, it causes undesirable social and psychological challenges, but also contributes highly to the adverse pregnancy outcomes that we're seeing. We've not been able to really identify how the vaginal microbiome relates to the asymptomatic or symptomatic reproductive tract infections, and how these infections then alter the vaginal microenvironment and the vaginal microbiome. In addition to this, we do not have good and easy to use tools that can be able to screen the pregnancies that are at risk, especially based on altered vaginal microenvironment. We know that with dysbiosis, or we have change within the vaginal microbiome, then you're likely to suffer from various consequences, both in gynecology and obstetrics. And these are some of the conditions that one can suffer from infertility to conditions such as low birth weight, maternal sepsis, and postpartum hemorrhage, preterm birth, and stillbirth. So it means that just getting to understand what's the vaginal microbial populations and what are the these bioactive substances, the metabolites released because of the bacteria-host interaction, are able to relate to the pregnancy outcomes. But also understanding this mechanism can give us ability to be able to develop easy-to-use screening tools and diagnostic tools that can be used at a point of care. Most importantly, we can be able to advocate for some of these screening tools to be used in the antenatal clinic to be able to change this trajectory of adverse pregnancy outcomes. In addition to that, by just getting to understand the biology, we should be able to identify various therapeutic targets that can be used in terms of treatment. And with that, it will also help improve the rational use of antibiotics, because we now know the issue of antibiotic resistance is quite a concern. And therefore, we need to get new tools in the toolbox to be used for treatment of such infections. This is a high value and met clinical and research need in our setting that our group then decided to focus on and do some work. The specific aims for this research was to be able to analyze the various vaginal microbial communities, and we are deploying the next generation sequencing. Specifically, we're doing the 16S RNA sequencing. And then we also want to be able to identify vaginal metabolomic profiles, and these profiles then we'll be able to catalog and see which are the most promising and predictive profiles that can be used to formulate a point of care or screening tool. And those ones that also speak to the adverse pregnancy outcomes. We've been following a large cohort of patients, also collecting clinical data, and this clinical data will be combined with the vaginal microbiome data, the sequencing data, and metabolomic data, and they will be put on a machine learning assisted forward prediction model to be able to detect what are these hidden intricacies between the microbiome that we find, the adverse pregnancy that we get, and the clinical characteristics of this patient. And this information can therefore be used to tell which are these pregnancies at risk and what defines pregnancies that are at risk based on the vaginal microenvironment. In addition to that, we've been formulating some work on One Health and just looking from soil to mouth to the gut and how this can be able to affect, how we practice the agricultural practices to enhance human health and what we should do and not do, and especially noting that microbiome science is central to guaranteeing the future of our health. And so one of the important things to just note here is that microbes serve as effective biocontrols and biofertilizers and biofortifiers, and this could be options that we probably be proposing in the future to just enhance not only women's health, but human health and animal health in general. So using these new technologies and following up our cohort of patients, we'll be able to determine what are these pregnancies at risk, and then we also develop tools and potential therapeutic targets that can give us an insight on maternal health outcomes. These are the opportunities for intervention, so likely to get new therapies beyond the broad spectrum antibiotics that we probably discouraging quite use of it because of the resistance, and then development of probiotics and prebiotics. And this will be formulated using our own strains because there's very little research done on the African group. So we use our own strain that can be able to develop probiotics and prebiotics. And as a result, it will be laying a very good ground to precision medicine practice and approach in African women. So transitioning to science advocacy and noting that there was need to shift to a community-focused initiative to show how our research that we do in the lab can actually be in action and create impact at a larger scale. We noticed that the scientists should not just sit in the bench and should just not be in the clinical at the bedside. We should also be able to bridge the gap between what science offers and where the action really occurs, because the policymakers that make decisions on what we need to do and where we need to invest. So we need to engage them really. So one of the big conditions that causes a lot of suffering amongst our women and maternal health is postpartum hemorrhage, and experienced by over 14 million women worldwide. In our country, it causes about 35 to 60% of maternal death. However, most of these deaths should not happen because they are preventable when noticed in good time and treated in good time. But there's a knowledge gap that exists between the practice that is done and what actually should be done, and sometimes sustainability and some of the changes that we get. In 2023, WHO came up with about 5 key points, 5 pillars to combat postpartum hemorrhage, noticing that it's the #1 killer of women in sub-Saharan Africa and Southeast Asia, and a big concern across the world. However, they noted that there was no unifying force that was put together to try and drive the PPH agenda and aggregate funding to make sure that this agenda is pushed to the next level. It's for that reason, and noting that we are the ones who suffer the most consequences of postpartum hemorrhage part of the world, that a collaboration between the Kenya Obstetrical and Gynecological Society, the University of Nairobi, the Midwife Association of Kenya, and the PPH Foundation came up and launched the fight against postpartum hemorrhage. And, as I've mentioned, if you note that the postpartum hemorrhage kills about 1.6 times more than road traffic accidents that happen in this country. Yet whenever there is an accident, there is quite a lot of attention given to that, which is okay. But whenever mothers are dying every day, there's very little attention. So this is a silent killer that needs to really be addressed in the room. So our key targets were to get the WHO agenda that put and be as a group lead this particular initiative. And we were in a theory of change to reduce PPH-related maternal mortalities and morbidities by a huge percentage. And of course, improve the skills of healthcare workers working in this particular space to manage PPH, and develop new tools also of managing PPH, and create awareness, because through creation of awareness that people are able to recognize and aggressively talk about and therefore manage postpartum hemorrhage. So our call to action in Kenya through this organized group, we were able to raise awareness and mobilize communities across. We were able to get and engage policy makers and healthcare stakeholders who initially would not be talking about this particular subject. And for the first time in 2024, October, we organized the first global PPH awareness run in Nairobi that attracted over 3,000 registrants, and over 1,000 people came physically to run. So we had a number of governors, senators, women representatives, World Health champions for Olympics, students, healthcare workers, and all stakeholders engaged in this particular run. Within our stakeholders, we had a wide base of them, and this flagship engagement attracted quite a lot of attention also from the media, and we got quite a lot of coverage, reaching over 500,000 people that year alone, with the support from various organizations that are listed here. So Leveraging on this momentum, we've been able to continue with stakeholder engagement and community, advocacy strategies. We've also been able to introduce a new concept that was based on one of our 4 key pillars, the roaming blood bank campaign. And within this roaming blood bank, we note that out of every 10 women that die per day in this country because of postpartum hemorrhage, 4 of them will die because there was no blood. And noting that the blood supply chain in this country is very wanting. Out of the very 500,000 units we need to generate every year, we are only able to collect about 200,000 units with a shortfall of over 60% to 70%. So we came up with innovation to be able to have blood, and what a better way of getting people to know their blood groups. And after knowing their blood groups, you put them in a system that then they can become sustainable donors through a roaming blood bank concept. Recently, we've been able to do this and collected about 400 units that have been given to various hospitals to help mothers with postpartum hemorrhage. And our advocacy is definitely anchored on the research and the research findings that we do. So building on this coalition that and our success last year, we've been able to engage and have the international run planned for this year. And 5 countries confirmed that will be participating in the run on 28th of September. These are Kenya, Rwanda, Zambia, and Tanzania and Uganda. And we have about 5 other counties besides Nairobi that will be running in Kajiado, in Makueni, in Mombasa, Uasin Gishu, and Nairobi as well. I've mentioned that. So this run is on 28th of September, this Sunday, and we are welcoming everybody to come and participate. And you can have a small caucus of run in your local area, because we believe that it's only real heroes that run for their mothers. Concluding this, the future of training and reskilling of healthcare workers, because we know healthcare workforce is a big challenge within this particular space. So what are we doing, and what are the innovations that we try to do to scale training and ensure that we are well prepared for providing women's health and women's care? It's for that reason that we are collaborating with a team from London, the virtual reality in medicine and surgery. And this collaboration is aimed at basically scaling the training, because we know the human resource gap is an issue. The ratio of our healthcare provision is 1.5 per every 1,000. We need a WHO guaranteed of 44 per every 1,000. So we need to train about 5.1 million healthcare workers in the next 4 or 5 years to be able to meet what we need to do. However, the training that we currently have is quite expensive, is time consuming, and often sometimes lacks standardization. And so that's where the virtual reality and extended reality comes in. And we believe through the virtual reality, we should be able to provide safe, repeatable, and realistic environment for healthcare training, especially for those who are doing in-service training, to basically build their muscle memory, to build their confidence, and make sure that they are able to address these conditions when they're met with them. I can guarantee, even for the most experienced obstetricians, when there's a mother pouring because of postpartum hemorrhage, there's always some level of panic. But if you've been doing this practice through VR training, you're going to have the muscle memory to do so. Augmented reality can be a personal assistant and can be able to guide you in real time during a very intense moment when you're managing. So this approach is highly scalable, and it can be democratized in many regions. So a single VR training module can be distributed and standardized training across the continent and across several clinics around. So last week we had this meeting in Guildford, and we'd be very happy to have this impressed in our training, especially for in-service training for our healthcare workers, especially those working in the women's health programs. So my call to action, as you've seen, this work demonstrates that there could be a powerful synergy really between the basic science work that we do and the grassroots engagement from the community to policymakers, and now adoption of cutting-edge technological solutions such as the metabolomics, microbiome work, deployment of AI-assisted tools, virtual reality, extended reality. So by combining these approaches, we can create a future where every woman has a chance to live a healthy and a full life. So with that, I want to thank everybody and invite any questions for interactions. Thank you. Back to you, Professor Ogada.
Ladies and gentlemen, you'll agree with me that that was really very, very powerful. Wherever you are, can we put our hands together and clap for Professor Obimbo? So thanks very much, Prof, for this incredible insight and inspiring presentation that you have given. Very, very impactful work you are doing outside there. It resonates very well with almost all of us. I don't think there is any single individual that does not know any mother that died at birth. It's a big challenge, and I'm delighted that you have presented to us today quite a number of possible innovation and opportunities that could be integrated in various health systems that we have in our countries, both in Africa and also beyond. So really, on behalf of my colleagues, to say a big thank you for this. I know there must be 1 million questions outside there. And of course, my colleague, Dr. Kilelu, will be able to read out the questions that have been put in the chat. But I wanted just to start by asking you, you gave us a small exams at the beginning, and now we may want to know the answer and also tell us briefly the implication of that. And even as you do that, you could also address 3 other questions just as a way of opening up. The first one is that what do you see as the biggest challenge in scaling up some of these wonderful innovations that you have come up with, particularly in low resource setting like Africa and other developing countries? The second is, from your experience, how can we better integrate this technological innovation in our existing healthcare systems? And then finally, I can imagine there must be outside there quite a number of young innovators who are saying, wow, I wish I were involved in this. How could they be involved in this field of maternal health? Over to you, Prof.
Thank you very much, Professor Ogada, for those questions and for the compliments too. Yes, so I think now the questions that were on the poll, people can probably repeat and get the right answer because now you're able to make calculations and get to know about how many women die every day. So it's about 800 women dying every day. If the estimate of 2023, 2024 were anything to go by. So that's a huge number because the question we'll be asking ourselves, which woman are you going to be choosing to die and who are you going to be choosing to live? So it really means no woman should die because of pregnancy-related complications or issues. So 800 is quite high. Now, you go to the the area of highest burden. I think everybody almost got it right. Sub-Saharan Africa, accounting for about 70%. When you combine with Southeast Asia, they account for about 83%. For the treatments, as I've shown the concern of use of antibiotics to treat. And so we really want to avoid that route because of antimicrobial resistance. And so getting new novel treatments such as probiotics, prebiotics, or syntibiotics would be a way to go, because then we want to really create this aspect of precision medicine at work. So those are the correct responses for the questions that were asked there. Now, the challenges in scaling up these kind of innovations around, and I think the issue has always been investment. And we talk about universal health coverage, but we've not been able to really walk the talk. So investment means really putting the financial muscle behind some of these strategies that we're going to deploy. Happy to report that there's been some talks, in the government that there'll be more investment, especially in adoption of ICT, in adoption of some of these new technologies, and looking forward to that really happening, because it then is a big inspiration to what we can be able to do. Because in this country, we have so many young, innovative minds that have solutions to our own problems. So sometimes they just lack investment. And investment would be all the way from training to really putting resources at the point of care, and just also making sure that we have good education for all that need to be aware, amongst other challenges. So how can we better integrate some of these technologies in our healthcare system? Seeing is believing, and the best way is to be able to actually get this in motion and in works. So from the work that we are doing on vaginal microbiome and metabolomics, it's still work in progress, but in the next 1-2 years, we should be able to get data that can be able to formulate what we're calling a potential screening tool. And the aspect of innovation here is to make sure that the tool that we get is affordable and scalable. So affordable means less money to use it. Scalable means you can produce in mass and be used in multiple places, and can also be used in areas that are considered to be remote. So this is really the background of the microbiome and metabolomics work that we're doing. In future, and using the science that we able to understand, the mechanistic approach, then we can also say, because of this change in biology, we can be able to create this as a potential target for treatment, or develop a molecule that can actually be used for treatment as a new life biotherapeutic. For the use of the extended reality, virtual reality, this is something that's emerging and it's new. Now we went to London, some of our few colleagues in Africa, and got this, we got some training, and now want to see how can we be able to scale this in form of training. Most importantly, as it happens in the training of pilots, they do a lot of simulation, and simulation is very good to give them dexterity, to give them muscle memory, and to give them confidence, so that if you're in turbulence, you're not panicking, you're not leaving the cockpit to go to the passenger side. So we hope that that kind of training will also increase and improve safety in women's health provision and maternal health provision by simulating various models that are very tough to comprehend and manage, and you do many times, and that gives you confidence to be able to do it. Mentorship is one of calling, and I'm working with a team of very young scientists in the lab. I also work with young students who are doing the undergraduate and they're interested in working with us. And we are also always open also to just listen to what new ideas we get, because sometimes the very best ideas we get are from the young people we're working with. So we are open to that, and we can always get them engaged. Thank you. Back to you, Prof.
Yeah, thanks very much. I know there could be some questions that are in the chat, but I'm encouraging all of us who are listening, please feel free to raise your question through the chat. Catherine, can you be able to read a few that are there?
Yes, tough choice, because there's so many people who have questions and comments, but I'll select a few. I'll start with some of the clinical ones. So one has asked about the effect of rhesus factor on pregnancy, so positive, negative rhesus, if parents have positive or negative, does it affect? And then another question is around the vaginal microbiome, and if that has an effect on abruption. So that's something to maybe respond from a clinical perspective. But other questions are around the health system. So question around the fact that in Kenya, healthcare is devolved, and that has affected the quality of care in the country. So what would be your response to the effect of that in some of the work that you're doing? Then another question is, can you kindly comment on the scientific capacity of our researchers based on the work that you're doing and whether we have adequate scientific and research capacity? So those are the few for now, round one, I think. Yeah.
Let's allow him to answer those, even as you prepare for the next round.
Yeah.
Thank you very much. Yes, thank you, Catherine. Yes, so some rhesus factor on pregnancy, I think that work has also been done by our team. And just looking at the burden of rhesus negativity in our country, some the very preliminary findings, we saw that the different counties have different levels of rhesus negative blood group. So we know when a woman gets pregnancy and she's rhesus negative and the pregnancy she's conceived, the baby is rhesus positive, what does in that pregnancy, it sensitizes the woman blood group, it enhances the immune cells. If she's not treated during that pregnancy or not tested for her rhesus factor and treated, then it means that she'll be sensitized. And therefore, during her next pregnancy, when she gets a fetus that is rhesus positive, her immune response will fight against the fetus rhesus positive blood group, and this interaction can cause fatality in the baby, can cause death in the fetus. Of course, there could also be other conditions like pregnancy loss, early pregnancy loss, and stillbirth, and so forth. So rhesus disease and rhesus factor, and just getting to know your blood group is very important as one of the management tools for having a healthy pregnancy. Effect of microbiome on abruptio, I assume maybe is an issue of placenta abruptio. We haven't been able to study this yet. We don't know yet, but we know the commonest cause of abruptio would either be a fall or trauma or very high blood pressure. But this would be something good to just check whether the microbiome or dysbiosis itself can actually have effect on the placental abruption. Devolution of healthcare and the quality of this provision. I think, in my opinion, that there's been quite a lot of concern about the different, healthcare systems in different counties, introducing so-called iniquities or inequalities amongst provision. And what's affected normally would be the women and the children, because the ones who will be seeking healthcare quite often. But this system can be strengthened through advocacy and just making sure that there's standardization and, of course, making sure that all the counties are able to account for what they do with the resources they're giving and are given for healthcare. However, I think there's also a chance to revisit and check what has been the progress so far with the devolution of healthcare compared to what was in the past, so that we have data and evidence-informed, decision and strategies. And then finally, do we have scientific capacity to do the kind of work that we do? Yes, Kenyans are taught very well. Kenyans are very brilliant. What sometimes we just do not have are resources for research and access to the grants that can be able to get us good research. But in terms of capacity and training is good. And there are quite a number of trainers who are able to offer this kind of training to our young people to be able to do the kind of work that is done elsewhere in the world. And a good example definitely is our own Professor Calestous Juma and his kind of research that he did in biotechnology and improving food security.
Great. I'm just looking at the time, and I think we're running short of time. But I'll just give you two more questions if you could respond to. One, I think I see Jerry asking that his grandmother helped many expectant women with complicated cases to deliver safely. So using herbal medicine. So is it possible to research and innovate around traditional medicine to help the condition that you're discussing? And then another one that I will pick randomly, not to say the others are not interesting, but just for the purposes of time. He says that most of the advances in medical technologies rely on energy, which is still a major challenge in the continent. So how do you think we can scale these innovations in the context of the energy challenge that we face? So those two questions. And I have to apologize.
You can add another two.
Okay, okay.
Just so it's the efforts of our participants.
Okay. Another one was asking about AI-enabled fetal monitoring software, which has proven to be helpful in reducing maternal and neonatal death. So what are your thoughts around integrating this technology in the healthcare system? And then finally, what precision medicine, how do you connect this with the notion of precision medicine, and how has it been explored in the context of sub-Saharan Africa? So
yes, thank you very much. Thanks for those wonderful questions. The herbal medicine approach and grandmother using them to help quite a number of our people, yes, I agree. And I'm a very great proponent of research in our own solutions and context-based solutions specifically. You realize if you go to countries like China and India, most of the products that we buy from, herbal products or herbal concoctions, or just improved version of the same now using the modern scientific approach. So I want to encourage the young researchers, even the old researchers who are interested in herbal medicine and traditional approach to medicine is really the way to go. Basically, we just need to give them the feel and the acceptability, and we should be able to have it integrated in our modern healthcare. Energy as a major challenge to innovation, yes, I agree. We need to innovate quite a lot in the energy sector. Is a big threat. And going forward, I think the need, especially if we're going to adopt AI and innovate AI to be able to help medicine in our own context, we need to invest quite a lot in the energy sector. There's a book that I would recommend, I think, How the World Really Works by Wycliffe Smith. And he talks about a chapter on energy and how energy is a big thing, not just in Africa, but across the globe. And so we need, as a country looking into the future, to have a great investment in energy as a baseline for future innovation and adoption of technology such as AI. AI-enabled fetal health. Yes, I think you've heard of point-of-care ultrasonography that's AI-enabled, just with the sweeps, even with the not very highly trained people or very highly skilled people, you can be able to tell what's the fetal presentation, where's the location of the placenta, is that the fetus have a heart or not, so you're able to tell very, very basic things, and it's changing how the obstetric outcomes would be. And so AI in multiple usages, not just in obstetrics, but also in gynecology. But of course, being an assistant at the point of care would be something that we cannot run away from. And I think going into the future, for us who are training medicine, we'll have to really integrate AI. And finally, the issue of precision medicine and how this is in our context. The world is moving towards precision medicine, and fast. We know that some of the medications that we've always had traditionally, we actually do not know the dosages that are right for our own population, because we could get maybe within a certain population, the metabolism of this drug is very high or the metabolism is very low. And so we need high dose or low dose. So there's some research. One of my colleagues is also Calestous Juma. He's working on a lot of pharmacogenomics to just look at what are these dosages appropriate for our population. So that's called population precision medicine. But then there's also personalized precision medicine, where we now get to know this is good for Obimbo, this is good for Catherine, and so forth. So we are on that level. And I think all of us who are interested in research and interested in practice, we have to really come to that particular front to make sure that we make a difference, not only in the population health, but our women's and maternal health. Thank you very much.
Wow.
Great. Prof, you want to wrap up?
Yeah, we would have wanted to continue, but because of time, I think what we can promise participants is that we'll be able to share with you all the questions, and if possible, then we can prepare responses and then see how to share with the colleagues. Otherwise, at this juncture, allow me to pass the microphone to Angela to now formally close the seminar on behalf of all of us. Thank you.
Thank you so much. Thank you so much, Dr. Obimbo. We're so honored to have you. This was really a wonderful relaunch of the Calestous Juma Legacy Series. So on behalf of the organizing committee, I want to just thank everyone who joined us today. You are the community that carries on the legacy of Professor Calestous Juma, and I hope you leave here today feeling inspired to take action on the topic that we explored together today. A special thank you to Professor Obimbo for your invaluable contributions. We are so proud that you are one of the Calestous Juma Science Leadership Fellows. Your expertise and your dedication have made this event just a tremendous success. So I'd also like to thank Prof. Ogada and Dr. Kilelu for their contributions to this event today, and thanks to our whole organizing committee for their hard work and dedication to bringing this series back to life. We did have one more piece, which was a poll about how you're going to take action, which I think we can promise we'll send out in follow-up materials, because we want to hold everyone accountable for taking action on this topic. So look forward to that. And we look forward to seeing you at our next event in this series. Please stay tuned for future announcements. And thank you again, and just have a great rest of your day.
Thank you.
So,
Great. Thank you very much. Thanks, Angela. Thanks, Professor Obimbo. Bye, everyone. Thanks for joining us, and see you again next time. Bye.
Bye now.